Welcome, everyone. We're delighted to have, I'm watching the numbers growing as we're going, and I'm here to welcome you to I'm an Educator too, creating inclusive, accessible healthcare spaces. I'm Shelley Cohen-Conrad, the director of the Center for Excellence in Collaborative Education, and we are sponsoring our LEND colleagues tonight in a very, very exciting and very important and informative presentation. I'm just going to do a little etiquette in the beginning. I just let you know that we want this to be as interactive as possible. And so, especially when you're in the breakout rooms, please get on your video and speak to one another and be respectful and listen and have a good time learning with and from each other. We have multiple professional groups here tonight, and that's the whole point. Welcome, Kate, one of our LEND folks. And so this is going to be an exciting evening for all of us. This is our last knowledge exchange for the spring semester. And later on, we'll be telling you a little bit about our IPE showcase coming up. So it is my great delight to introduce our panelists, our lead panelists tonight. Grace Finn is a second-year doctoral student at the University of North Carolina at Greensboro and Specialized Education Services. She has a very interesting history. She is, prior to beginning her doctoral studies, Grace spent 4 years as an occupational course of study teacher, preparing high school students with mild to moderate disabilities to transition to the world of work. During her time as an educator, she noted several issues in the area of transition, which were then exacerbated by the pandemic. Grace's current focus in her studies relates to identifying barriers to and facilitators of competitive integrated employment for people with autism. We're going to learn an awful lot tonight, and I am ready to turn it. Welcome, Grace, and welcome to the panel.
Thank you so much, Shelley. So hello, everyone. As Shelley said, my name is Grace Finn. I'm a second-year doctoral student at the University of North Carolina at Greensboro. I am also a leadership education in neurodevelopmental and related disabilities, also known as LEND for short, trainee here at the University of New England. And I am so excited to be here tonight to engage in what I hope will be a very informative knowledge exchange about increasing access and inclusion in healthcare spaces. I won't lie, when I was first approached by LEND and CC about putting together information for this knowledge exchange, I was excited, but felt a little bit like a fish out of water, because I immediately realized that while I was very well versed in the concepts of accessibility and inclusion through my work as a special education teacher, I had absolutely no idea how any of these things might translate into a healthcare setting, which is why I am just so extremely thankful for the other trainees who are here tonight, who have shared so much of their expertise with me. And I'd like to give them just a moment to introduce themselves now.
Hi, I'm Jenna Carey. I'm a third-year physical therapy student, and I'm also a main LEND trainee.
Hi, I'm Sydney Wolf. I am an advanced year Masters of Social Work student at UNE, and I'm also a social work trainee for Mainland.
Hello, I'm Ali Kashadi, Master of Occupational Therapy student and main LEND trainee.
Hi, I'm Andrew Whistler. I'm a self-advocate with the mainline program, and also a trainee.
And that is all of our panelists. Thank you so much for introducing yourselves. So taking a quick look at our agenda for today, we're going to look at universal design first, because I think it's something that we all might be familiar with, even if we don't know the name of it. And then we're going to move into universal design for learning, which is going to be the bulk of the knowledge exchange today. We'll have our first interprofessional discussion together, and then we'll come back together to see how we can translate this educational framework into a healthcare setting. And then we'll have another discussion together, and then we'll open it up for Q&A. So we're going to take a look at some of the answers from the poll about barriers to healthcare that people encounter. I'm noticing a lot of the common ones, right? Like insurance, cost, finances are some big ones. Transportation is a huge one.
I'm wondering if that's specific to Maine, if folks in Maine are feeling like that's a particular issue we have up here.
Yeah, I think probably true here in North Carolina too, especially with finances being a barrier, because we know healthcare can be very expensive. But we're also seeing things like education and jargon, stigma, or signage, communication, unequal access. So I think what this word cloud does nicely is it demonstrates that there are some common beliefs about some barriers to healthcare that people encounter that we might first think of when we think of barriers, but there are a lot of other barriers too. So we're going to talk together tonight to see how we could mitigate some of those barriers. So before we get into universal design for learning and kind of the bulk of our material today, we're going to start with something that probably looks pretty familiar. You've probably seen these things before. So on your screen, there is a picture of a curb cut, closed captioning on a video, and a button that opens a door either on or inside a building. I want you to take a minute, and you can use the chat or unmute, whatever you're comfortable with, and share who you think these things are designed for, who benefits from them. I'm seeing lots of everybody's. Sydney made the point that traditionally may be designed for people with disabilities, but everyone benefits. You're seeing a focus on the physical aspect of disability. Yes. Audrey shared that her daughter loves the buttons on the door. Me too. Everyone benefits, but they wouldn't be in place if not for a shared goal of helping people with disabilities. Absolutely. Shannon's son uses the bumps on a curb cut on the sidewalk as he is visually impaired. Yeah, so you all really nailed it, right? We know that everyone benefits from the use of these things. A person pushing a stroller or using a wheelchair would greatly benefit from the use of a curb cut. But I personally have elderly neighbors in their late 70s and 80s, and sometimes stepping up onto a curb is really hard for them if they have some balance issues or limited mobility. And I don't know about all of you, but I am an avid user of closed captioning when watching movies or TV shows because I feel like it helps me like pay attention better almost. I'm more in tune with what's going on in the scene rather than just listening to it. I can listen and read. And then I'm sure we have all utilized those buttons that open doors on the building at some point, whether it's because our hands are full or because we love to press them. And then I know during the pandemic, a lot of people use them with their elbows, hopefully not their foot, so that they didn't have to touch the handles on a door. Next slide, please. So all of these things fall under an umbrella term called universal design. And universal design is a term that was coined by Ronald Mace all the way back in 1985 as a way to kind of describe the idea that many people, whether disabled or non-disabled, benefit from a more accessible built environment. Ronald Mace was an American architect who contracted polio when he was 9, which resulted in affecting his ability to walk, and he had to use a wheelchair for the remainder of his life. And then at this time in history, universal design was not a practice used when constructing buildings. So when he attended North Carolina State University, he had to rely on other students to carry him up and down the stairs of university buildings. So he became a champion for universal design to promote access for all. One thing to really note about universal design is it's not about accessibility for just disabled users, but rather a common sense approach to good design for everyone. So universal design uses words like equity, flexibility, but it never refers to a specific user. It doesn't ever refer specifically to people with disabilities as the beneficiaries. So moving beyond the physical environment, these ideas can be used to kind of change the way we think about accessing and presenting information. If you have ever been in a classroom as a learner or an educator, you know that no educator is going to present material in the same way, and no student will learn that material in the same way. So looking at our image here, while some students might need step-by-step instructions to successfully complete an activity, another student might just need a picture. This is a pretty good representation of myself and my husband. I am the step-by-step direction needer, and he can just have a vision in his mind for what it needs to look like as it's complete. And we just both work in very different ways. So how do we even begin to provide these access points outside of the built environment? How does this look in an educational setting? So we do this through this concept and framework called the Universal Design for Learning. And UDL is a framework that is used to improve and optimize teaching and learning for all people based on scientific insights onto how humans learn. So again, something really important to note about UDL, which we also saw in Universal Design, is that the only user listed is a human. Anyone can benefit from the use of these principles. So there are three main components to UDL. We have engagement, which is the why of learning, representation, which is the what of learning, and then we have action and expression, which is the how of learning. And these three components are going to kind of serve as the roadmap for our conversation today. I'm going to define each component and talk a little bit from an educational perspective about what that might look like. And then we're going to really dive in and talk together about how these principles can be easily translated to be implemented in healthcare settings. So we'll start with engagement, the why of learning. We know that information that is not attended to or that does not engage learners' cognition is in fact inaccessible right off the bat. And relevant information goes unnoticed and unprocessed. When sharing information, it's so important that we engage the learner and involve them in the process of learning. So they are a part of this, right? Engagement in UDL is the why of learning. And then that's broken down again into three subcategories. We have recruiting interest, sustaining effort and persistence, and self-regulation. So recruiting interest really requires us to consider individual choice and autonomy. It requires us to connect learning to experiences that are meaningful and valuable and create a safe space to learn together. So what this might look like, one thing that we might have to do is consider the level of perceived challenge. Sometimes just thinking something is too difficult is enough for us to not want to try. And I won't make you raise your hands, but I think that might resonate with some people, right? If we already think, that's just too hard, I don't even want to attempt that right now. Many students prefer to take the path of least resistance when they're given a task they've deemed as too hard or something they can't do. And this is why it's so important to involve students wherever and whenever possible to set their own learning goals and help them determine what's personally important to them. And then we have sustaining effort and persistence. Motivation is crucial for sustaining effort and persistence. If we think back to the example that I just gave, where a learner perceives something as too difficult, chances are they might not want to even try. I had a couple of conversations with some students throughout my years as a teacher where I'm like, just try. And I promise we'll make it through together, right? And we had to really have that conversation about what's going to motivate them to do that. I am perfectly happy with admitting that I am not a math person. And if there were any math educators in here tonight, they would probably vehemently disagree with me that math people even exist and that everyone can do math. But for me, growing up, math was very difficult. And sometimes it could be really challenging to motivate myself to put the effort in. To sustain effort and persistence, we might consider helping students with realistic goal setting or emphasizing personal outcomes and growth. We might think about creating communities where students learn together, providing prompts that guide learners in when and how to ask peers or teachers for feedback or for help, and then making sure that any feedback given is frequent, timely, and specific. And then our final why of learning is self-regulation. So the ability to self-regulate means knowing how to strategically modulate emotional reactions or states in order to be more effective at coping and engaging with the environment. So this might look like teaching individuals new approaches or strategies for dealing with different emotional states, so they are still able to cope and engage. We might have individuals chart their own behavior when using a new strategy, have them really think about what are they noticing, right? It can be really motivating to see behaviors either increase or decrease depending on what it is you're working on. I don't know how many of you are familiar with bullet journaling, but there are plenty of templates out there for mood or habit trackers where you can kind of sit down at the end of the day or the beginning of the day and reflect on how you're feeling or whether you drank enough water that day, and then color it in. And it can be really motivating to look back on your week or your month and see that you've met your goal or you've improved. So our next UDL bucket is representation. As every single one of us in this Zoom room right now know, none of us learn the same way. Some of us might be able to just sit in a lecture and absorb through osmosis, right? Every word that is said. Others might rely on videos or pictures to help understand concepts. So representation is the what of learning and is again broken down into 3 different categories. So we have perception, language and symbols, and comprehension. So perception requires us to consider how the information we are presenting might be perceived and understood. We know that none of us learn or access information in the same way. So that requires us to be flexible with how we present the information. And it also requires the information we are giving out to be in a flexible format. In order to do this, we need to consider the size of text, images, graphs, tables, all that good stuff. And we want to consider the contrast between background and text or image. So you wouldn't want to use black text on a darker colored background or vice versa. And then as a general rule of thumb under UDL guidelines, font size in a presentation should be at least 24 point. That's just a little fun fact for you. But we should be mindful of all of that. We should also be mindful of the volume or rate of speech. Many people benefit from a slower rate of speech when receiving instructions or information. I've had to sit down with myself and have many conversations over the years, especially when I'm excited about something, to say, okay, Grace, you need to just slow down and take a breath because no one is getting any of what you're saying. You could also use text equivalents for auditory information through the use of written transcripts, diagrams, charts, etc. And then consider using the alt text function for picture descriptions, or use physical objects or models to demonstrate or explain concepts. So in the field of special education, and in your fields too, I'm sure, there are probably a million different acronyms or pieces of professional jargon we use when communicating with each other, almost like our own secret language. When we talk about it in special education, we call it alphabet soup because there are just so many little acronyms for lots of different things. But this can really prevent others from accessing the information we're trying to communicate. So for that reason, we want to make sure that we are using plain language as much as possible. We want to be sure that vocabulary is explicitly defined and that our choice of symbols or text doesn't get in the way of what we are trying to communicate. And then we have comprehension. So comprehension is not a passive process. It's an active one. We have to be really involved with comprehension. It requires the learner to use active information processing skills. So when I was teaching, building on my students' background knowledge was very important to me because I found that making these connections to things they'd learned before made new content more accessible, since they had some context around what they were learning and they weren't just being thrown into something new. I'm sure you've had professors or teachers before that have been like, hey, remember that thing you learned like so many years ago? Well, this is kind of like that. And now we're going to learn some more about it, right? And another thing that I always wanted to be sure of is that the information that we learned together in the classroom could generalize to other contexts. So it wasn't enough for me that my students could add and subtract decimals on a worksheet in the classroom. I wanted to know that they could do it when purchasing something at a store or when making change. So we would take our learning further by using Monopoly money to make purchases in the classroom. Another one of my coworkers took students up to the vending machines and had them make purchases there. So just making sure that those skills are not isolated to one setting. And then our final bucket is action and expression, which is the how of learning. Much like we all learn differently, we also demonstrate our understanding in different ways. The most important thing to remember about action and expression is that there's not one means of action and expression that will be optimal for all learners. So we have to provide options for people to show what they know. Our final 3 subcategories are physical action, expression and communication, and executive functions. So sometimes the way that we present information can be physically limiting and we don't even know it, right? Turning pages, writing in provided spaces if they're really small, using a keyboard, all of these things might be limiting to different learners. So it's important then for us to provide materials with which all learners can interact or really be conscious of the individual needs of the students in our classroom. Providing multiple ways for learners to communicate their understanding is crucial to determine whether or not they understand ideas or concepts they've learned or can demonstrate certain skills. So, for example, when we're thinking about expression and communication, a learner with dyslexia might be able to sit and tell you a fantastic story during a conversation. They can remember every detail, the sequencing, all of those amazing things that we would expect from a story. But if asked to write it down, that might be too much of a barrier for them to communicate that entire story in writing. So we're really having to think about, okay, how can I help this learner show me what they really know? And then last but not least, we have executive functions. Executive functions are the mental processes that allow a learner to take advantage of their environment. However, executive functioning has a very limited capacity due to our working memory. Our executive capacity is sharply reduced when we have to manage lower level skills and responses. And then it can also be impacted by some disabilities, such as ADHD. The UDL framework seeks to expand executive capacity by providing supports and scaffolding these lower level skills so they require less executive processing, and also scaffolding the higher level skills as well to provide support there. So this is done through helping learners set challenging and authentic goals, but then also coming up with a reasonable plan for reaching those goals. So this might look like providing a learner with graphic organizers or note-taking guides, or providing different methods for them to participate in self-assessment. So that might be through peer feedback or role-playing. There's lots of different ways that you can support that. So I think that brings us to our first discussion. And I'm going to pass it over to Shelley to go over some logistics regarding the breakout rooms.
Thank you, Grace. I've already learned so much. Thank you so much. So we're going to go into our breakout sessions. We're going to meet for about 10 minutes. For those of you who have been in our breakout sessions before, you know we like you to select someone to take notes and to be able to report in the chat and back to the larger group. And we have several prompts here to think about as you're meeting with your team there. And we'll have you hopefully have very lively conversation. And as I said before, be ready to keep your video open and meet and learn with and from one another. So let's get into those rooms for our 10-minute conversation. It's great to see you. We had some really great discussion in our room, but I'm curious about what other folks have to say. It'll take a little. It's important to remember mental health is healthcare, even though it isn't often thought of concurrently. Thank you very much for that, Elliot. I think that's something we just began to talk about in our room about, stigma and reactions and dealing with mental health as well. I know there's a lot of comments here. There was a lot of conversation about, variability in accessibility. There were some, especially about how healthcare facilities are designed, that, how confusing the layouts can be, especially for people who perhaps have vision impairments or have mobility impairments, and also for older adults who I think it was Jared who said, you just have to realize that as you get older, you're going to have issues with various kinds of body impairments. So I'm really curious to hear from others, other facilitators. What did you hear in your rooms?
So in room 1, we really focused on, for the first part of the question, just what advocacy looks like for disabilities. Haley gave an example of using social stories at appointments for all children. So social stories are usually designed to be used with children who have autism to kind of prepare them for an appointment or something that might be happening throughout the day. But they're giving them to all children now. And so the kids know what to expect at their appointment. And so do the parents. So that was really nice. And then we talked about reducing medical jargon and how important that is to be able to communicate your point.
Audrey, you are talking about the I do, we do, you do, and that's part of osteopathic education, but other education as well. Would you like to say something about it?
Sure. So we talked about, we had a couple first-year comm students and we had a dental student, and both the comm student and the dental student talked about how, I forget what it is. Somebody remind me all I remember is cheer, like at the end you cheer for them. Remind me what they are, but it's these like kind of phrases that they're sort of, ingrained when they work with people. So as an educator, it's called the gradual release of responsibility, where it's the I do, which is the modeling, the we do, we'll do it together, and then you do it and you do it on your own. Oh, thank you, Kaylee, do for, do with, and cheer on. And we found out that the 3, and Kristen and show, tell, do. So we found out our 3 kind of professions all have that sort of kind of like core piece to how we educate our patients and students, which I thought was kind of cool.
I'm just wondering, I don't want to put anyone on the spot, but I know we have quite a few osteopathic medical students here, and I'd love to hear from you about how you're learning about that and using that in your environments. Okay, I am putting you on the spot. Any osteopathic students want to speak up? All right, I guess not. So I'll point to Karen Hussman and say, you were talking about diabetes education and about the importance of providing information in text as well as in verbal methods. Can you say something more about that, or someone in your group?
Well, I can start out with the part that I was most familiar with, which is, the importance of the multiple formats of information being presented. And I think we agreed that both as patients and as providers, we could really see the importance of that. And then I hopefully maybe someone else in the group will chime in about the diabetes information, because we had a current nurse, one of the trainees who's a nurse at Maine Med, and I think also perhaps a nursing student. I'm not remembering exactly right now. I'm sorry, everyone. But with some really great ways to teach kids about type 1 diabetes and to show how you would give injections and to really start to educate about diabetes in a way that children and families could understand and take in.
So multiple ways of presenting information, not assuming that there's one way to go and not assuming everyone is comfortable, sort of, I put in the chat a while ago, you need both empathy, the ability to stand in someone else's shoes and see the world through their eyes, and you need flexibility because, the method you may have planned isn't going to be the one that works. And, working with the person to decide what the best form of communication is important. So thanks for that. I see Molly from room 3 discussed the ability for having resources and how professions have to prioritize patient education. And we also talked about how important having translators. And Molly, that was something I was going to mention. Can you say a little bit about what your group talked about?
Yeah, we just talked about how, like, if patients are coming in, they might not really understand fully what's going on at first, and especially if there's a language barrier, having like a translator there ready for their visit and expecting it. But also, somebody in our group brought up how, like, you're able to get like translators over the phone. So that can be like a pretty easy way to, if you don't know it beforehand, and just making sure that, like, by the end of the conversation or the interaction, that like everybody's on the same page.
Great, thanks for that. I see Sydney, your room also talked about variability, and Emily Thomas, I'm assuming there might be more than one Emily here, that you talked about advocacy for disabilities equality, and I'd love you to say something more about that.
Participants in my group was talking about how in the occupational studies program, there's a strong focus around advocacy. I'm not sure if she would want to share.
From someone from OT that advocating for disabilities equality. Well, maybe one of the panelists would like to chime in on that, the importance of not only doing treatments with your patients, but advocating with them.
I think that there's, as healthcare providers, our role is not only to care for our patients and to educate them, but I think also to be standing behind them and next to them and encouraging them, in whatever other obstacles they might be facing aside from the care that they're receiving, whether that be, insurance issues or, general accessibility to education. I know as a social worker, we can be in so many different settings that, our clients are facing a lot of different issues. And so there's a lot of advocacy work that we can be doing to improve access to not only healthcare, but also to education services and other things that, just kind of generally improve our lives. So whether that is advocating, with an insurance company or doing more legislative advocacy, it's just kind of important to keep that in mind as well.
Right.
Thank you, Shelley.
Thank you, Sydney. And Jess, I know we only have a minute, or less than a minute now, but Kate, you brought up a really important point that we really also need to consider the contingent factors, adverse childhood experiences, trauma, how those affect accessibility and functionality. Do you want to have the last word?
Yeah, I just wanted to say that our group talked about that some healthcare experiences are anxiety provoking, and no offense to our dental colleagues, but that was one of the areas that we talked about, and in other areas as well. And some people are more prone to having high anxiety, since people who are on the autism spectrum might come into all those experiences with higher anxiety. And then, of course, there's trauma and adverse childhood experiences. So all those things also affect our ability to learn and take in information.
Thank you. And now I will pass it back to Grace.
Thank you so much, Shelley. And thank you all so much for sharing your thoughts and ideas. So in the spirit of UDL, I am now going to recruit your interest by showing you a video that really encapsulates our why. Why is it so important for us to be having these conversations today? And why it's so important for us to make sure our practices and services are accessible for all people. So we're going to take just a few minutes to watch a video and hear from Andrew Whistler. And Andrew is our self-advocate trainee in the LEN program that we're a part of. And he recorded this video with his mentor, Dr. Kate Lucas, on what he finds challenging when accessing healthcare services. And then also he provided some really wonderful suggestions for how we can make improvements that are small and yet really impactful.
All right, Andrew, thanks for talking to the group today. And could you tell us a little bit about things that get in the way for you when you're talking to health professionals?
I suppose I can stutter about things. I can trying to develop my thoughts gets in the way. Also, use of words that I might not necessarily know or understand. I suppose giving too much information, it's hard for me to know what is most important. Talking to my parents versus talking to me is a tough thing. Allowing for wait time to process information, and thinking if a professional asks like how I would answer that question. Also, anxiety about a procedure can get in the way.
Thank you. So now tell us, because you're a real expert at this, what things might help?
I suppose things that might help would be reviewing things ahead of time and afterward. Having a written outline would certainly help me. Highlighting the things that are important to know or follow up. Reviewing things before and after. Assuring that I'm comfortable and not too anxious about things. Making sure to talk to me, not to someone that I'm with. Also giving wait time and having me talk back how I understand how I understand the question or thing, what is being discussed at the end.
So Andrew's video is just one example of how using the principles of UDL in healthcare can be beneficial. And we've talked in detail about how UDL supports learners in a classroom. So now let's take a closer look at how the principles of UDL translate into healthcare settings. And I am going to pass it over to Allie to get us started.
We can engage people by meeting them where they are and adjusting our approach to their values, skills, and interests. We recruit client interest by providing choices and autonomy over their own healthcare. Knowing that health literacy can be a barrier to client outcomes, we need to assess learning needs. We can assess the learning needs of each client throughout their care, looking at areas like values, social background, attitudes, motivation, and barriers to learning and communication, like physical, emotional, cognitive. In healthcare settings, we should document these findings and report them throughout our interprofessional teams. Consider starting with a simple question like, how do you like to learn? To reduce the barriers of health literacy, we can use plain language, which is clear, straightforward explanations using as few words as necessary. Teach people at a basic level. Do not assume. Don't assume that they can read or write. Don't assume that if they can speak a language that they can read it. The only thing we should assume is that everyone may have difficulty understanding. How else can we further engage people in their care, improving health outcomes? By fostering relationships. Clients need to feel safe, supported, and respected. We can provide client education on eye level, respecting their role as experts in their own lives. We can help clients feel supported by using a caring voice and attitude, making eye contact, and using comfortable body language. Ask, what are some things you've done in the past that have helped you manage your medical condition? Our role can be to support people's efforts to improve their own health. If you can't relate to a client, can a peer support fill that role? It is our responsibility as healthcare providers to respond to each client and their specific learning needs.
So when we think about representation in healthcare, we want to be inclusive of all health literacy levels. So this means that medical jargon should not be included in documents that we are giving to patients. So this could include things like home exercise programs, information about medications, or anything specific to their injury or pathology or why they came to see you. So by using simplified language and presenting the information in different ways, we'll be able to alleviate barriers that our patients often face when trying to understand their own healthcare. So a few examples that I can share that I've seen and used in physical therapy clinics are, so when teaching a patient about exercises or their specific pathology, I'll often bring out an anatomical model of the part of their body that's injured or is diseased. And I'll often show them on the model because it gives them an actual visual of what it looks like inside their body when they're doing an exercise, where their pain is, and how I can help alleviate it by using certain modalities. I also provide patients with exercise programs by printing out pictures and diagrams of someone actually performing the exercise and their simplified instructions. And then I also tend to email videos of the exercises so they can watch someone doing the exercise, and the videos are able to have closed captioning and it can be slowed down to ensure that it's truly following UDL principles. And lastly, I use what's called the teach back method, which someone mentioned in the chat earlier. So thank you. So this means that after explaining something to a patient, I'll ask them to repeat it back to me to really make sure that they're understanding what I'm saying. And we should never assume that just because you're giving all this information to a patient that they're actually understanding, because it can be really overwhelming if you're throwing a lot of information at them or giving them just a packet to read at home. You really want to make sure that they're able to say it back to you and ask any questions while they're there with you. So yeah, I've definitely been seeing the healthcare system move towards this kind of multimodal approach, and it's really been mitigating barriers.
Thank you, Jenna. So speaking of kind of that multimodal approach, when we're thinking about action and expression using UDL in healthcare settings, we can think about using multiple forms of media or tools to communicate. So that might include different forms of assistive technology. So that could be things like using voice notes or taking written notes or typed notes if that's the way that someone prefers to kind of keep track of things that they're learning. It could also include various forms of communication. So whatever kind of modality that person receives information best. So that could include phone calls or emails or texts or, written information via mail. We can also think about the different ways that we break down the information that we're sharing with people. So that can include, as Grace had previously mentioned, scaffolding. So breaking things down and helping to support different areas of functioning for someone, as well as differentiation. So really individualizing the information that we are sharing with our clients or our patients. So as Allie mentioned, that includes things like asking them how they learn best. Or, what has worked well for them in the past or what hasn't worked well for them in the past, and really thinking about how we can tailor our approach to providing care to what will best fit their needs. If they know that they do really well with visuals, but they have a really hard time taking in information via hearing, it might be very helpful to give some sort of informational outline for them that they can kind of follow along as you're presenting information to them. Next slide, please. So the other piece of this includes executive functions. And so executive functioning is something that a lot of people with disabilities can struggle with, but it's also something that, everyone in general can struggle with and can really benefit from additional supports in. So this can include things like, helping people to set appropriate goals that, they'll meet within a reasonable time to mitigate them getting discouraged, to help them be able to kind of follow on a path in which they will be most successful, as well as kind of creating different steps that they can follow to achieve those goals. So Grace previously mentioned using something like a graphic organizer. So maybe for, healthcare, it can include something like laying out the steps in which they need to take in order to see some improvement in their health functioning. So in mental health care for social work, that might look like, some steps, some coping strategies they can use to reduce their anxiety from day to day, or perhaps something like that. We can also generally kind of consider the ways in which we support our clients. So, mental health professionals, social workers are trained to notice signs of dysregulation in our patients and kind of support them through that. But that is not training that all healthcare providers receive. And so it's great practice just to kind of monitor how your client is taking in that information, what their body language looks like, whether maybe their voice is shaking, if they are fidgeting a lot, if they just generally kind of look nervous. It can be really helpful to kind of check in with them to make sure that they're taking in all of the information that you're presenting, but also, that they're feeling good about it, that they don't have any additional questions, and that they're just generally in a good mental space.
Okay, thank you, everyone. That was really helpful. Great examples, great suggestions. So now we're going to go into our final breakout session. I know some folks have had to go, but we're excited to rejoin our teams. And we're going to be thinking more about how we might think about using UDL in our own practices, and also connecting the dots around diversity, equity, inclusion, accessibility, and belonging, which was a topic we brought to everyone a couple of weeks ago. So let's go into our breakout rooms. Again, we'll have about 10 minutes to chat. Great conversations, and we're getting a lot in the chat. So let's hear from you. What did you learn about, I think our talk we spoke a lot about how diversity, equity, and inclusion, how UDL is speaking to that, and how people have encountered various experiences of inequitable situations. And I'm going to call on facilitators. Anyone want to speak up and talk about your group, or grab one of these comments? I see Elliot has put quite a bit in here.
I was gonna call out a comment that he typed in. Elliot's been a great ambassador with his typing in the chat. So I'm just gonna quote it. He said, "What is all the research and training we undergo as healthcare students worth if our delivery of patient care is hindered by barriers of communication, comfort, and trust?" So we were just talking about how this is like really, really foundational, and yeah, can be the way that we teach or present information can be a gateway, or an open gate or a closed gate.
Elliot, I see you on the screen. Would you like to say something to your fans?
Well, I have to give Allison credit. That was actually her comment. I was just scribing for our group. But I think that we said a lot of things that kind of echoed that, just in different words. But it's the idea of being a bridge between science and the general public. So we, as healthcare future healthcare providers, current healthcare providers, people who are involved in medical research, people who are educators of healthcare students, we all spend probably more of our time interacting with the scientific, academic, informed spheres of influence, groups of people who we work with. And so our responsibility is to make all of that information accessible to the general public that comes to us seeking help, which ultimately is coming from research and scientific inquiry. And so we have to put ourselves in a position where we're able to make that information digestible and understandable to people who haven't had our kind of training and regular interaction with that whole world.
Thank you for that. Anyone want to comment, respond to Elliot?
I just wanted to say thank you. I thought that was really eloquent.
Yeah.
Very much appreciated.
Yeah, I advise you, if you haven't taken a look at the chat, there's quite a bit of reading that's really, really powerful in there. So thank you, Elliot and Ali, for that. We have group one. I'm wondering if someone from group one would like to talk about the fact that breaking down barriers, equity does not equal equality. Everyone has a different set of needs. So who from group one would like to make some comments? I know, Grace, you were the facilitator in that group, but I'm wondering if someone from your group would like to add to that.
Yeah, I think it was Mary who said that about, she was talking a lot about equity and equality. So I would love for her to share that with everybody.
Hello. I was just talking about how equity and equality are not the same thing, and where it's really like we need to be cognizant of that when we're in these situations. And equal really means that everybody gets exactly the same thing, whereas equity means that you're getting what you need, and really, again, being cognizant of the needs that are being presented by the population that we're serving.
Great, thank you. Shannon, I would love for you to speak to how happy it's making you to know that future providers are having these conversations and thinking about these issues as a parent of a child with a visual disability.
Sure. I mean, earlier in the chat, I mentioned I had read the New York Times article about doctors not wanting to treat those who live with disabilities, and it really was incredibly sad for me. So the fact that we have some future doctors in our group who spoke up and said that they're learning in their classes or they're learning in their practicums of ways to have inclusiveness and to make sure that their practices will be welcoming in the future. It just, I don't know, it just kind of warmed my heart to know that there will be practitioners out there who will welcome with open arms everyone.
Great. Thank you, Shannon. And thank you all for being willing to have me put you in the spotlight. And I think I'm getting it back to you, Chris. No, it's me. I'm introducing the poll. There we go. It's late. So in this poll, we really want to hear from you what you've learned about UDL from today's speakers and also from each other with your powerful conversations. And again, you can either use the QR code or you can go to Poll Everywhere UNECC and get the poll questions. And we will be watching for your responses. I love watching these move. So appreciation for applying these principles seems to be pretty powerful learning from tonight. I guess so many people, I feel like Shannon, that, we're so happy that our students are going to be graduating and becoming clinicians and providers who really appreciate these principles of universality and really thinking about the design of spaces, and not only spaces, but communication that benefits everyone, all of our clients and patients, but pays attention to those who had particular physical or emotional behavioral needs. I'm really glad we didn't get any F so far. This is great. Yes. Looks like interprofessional awareness was increased as well. I mean, lovely conversation between and across our professions about, again, something that's universal. So we had some affirmation. We had some raised awareness. We had appreciation for the benefits. And all in all, panel, fantastic job. So. So now I'm passing it back to you, Grace.
Thank you. Thank you so much. Yeah, I'm gonna bring us home. So when we address the disadvantages or exclusions experienced by one group of people, we create an environment that enables everyone to participate and contribute fully. So this process of re-envisioning ideas into a new environment will, of course, take time and effort. But the rewards really are tremendous, especially when it comes to the health and safety of those people who come into your care. So I'm fully aware that expecting everyone to walk away tonight with every UDL principle memorized would be unrealistic and unreasonable. But what we do hope you walk away with tonight is a new understanding of what it means to provide care that is accessible to all people. One of the best labels I was ever given by a professor was lifelong learner. I got that back in my undergrad and I've carried it with me. And if you're here this evening, then I would say that you all possess the qualities of a lifelong learner. And as such, it is our responsibility to be reflective in our practices and continually ask ourselves, are we doing what's necessary to help those that we encounter in our careers? So whether that's in a classroom or a medical office or a hospital room, we are all charged to be educators in our own right to create accessible spaces for all. So I just want to thank you all so much for your time and your participation this evening. I know my contact info will be provided in just a moment for those of you who might have questions later on, but I'd love to open it up for some Q&A for myself and our panel, for anyone who might have a question. Can't say we'll have an answer, but
I was just going to say, it'd be lovely to hear last remarks from all the panelists, about maybe what they learned or what they are taking away from tonight. So Sydney, Allie, Jenna, you have something I'd like to share. Maybe we can just take the slides down for a minute.
Yeah, I can go first. I said this to the folks in my breakout room, but I feel like this is a very neat conversation to be having right now. If you were to Google UDL in a healthcare setting, there's nothing sort of there on the internet because this is so novel at this point. But yeah, I just feel like this is a conversation that's going to explode. Can and should be exploding, listening to the voices of people with their lived experience, and just really designing environments that just accommodate a variety of needs to benefit more people. So this is cool. Thanks for coming.
I'll second a lot of what Allie said. And I agree that, this is really a timely conversation to be having. And as a social worker and a LEN trainee, it's really awesome to be able to kind of see this part of my world come together with, the interprofessional education I've received at UNE, and really start to encourage the conversation around improving access to services, not only, improving that interprofessionalism, but improving access for everyone. And so it's just awesome to be able to be a part of that conversation. So I just want to thank you all for being here and thanks CC for being such wonderful hosts.
Yeah, I had a similar takeaway. The people in my breakout room had really good examples of how they've already used UDL principles, but then also gave examples of how they can use it in the future to create more access to healthcare and really include all individuals. So I want to thank everyone for all of their great ideas and for sharing all of your experiences.
And I think we need to do a shout out to Andrew, who provided amazing information to all of us. I see we're shouting out here. Andrew, thank you so much.
Yep. Thank you. Thank you. Yeah. I think it was really, I think it was really good, and I really learned things about UDL too that are, I think that that really good. Just like making things more descriptive, and I think just like I really kind of learned how it really does change, how our understanding has really changed as we get older, and I think it's and I think it was really I think it was really good to discuss this too. It's so yeah, there's a lot of things that I really learned out of this, and so thank you.
Well, thank you for being a great teacher, and thank you all for being a great panel. And we just continue to learn. You're getting lots of kudos in the chat, so I guess I'll just tell you, come back to say thank you all, and to remind you that our final CC event for the season will be our Interprofessional Student Showcase, which will really literally showcase students' work that they've done together in teams. And that is April 26th at noontime. Watch your emails so that you can come and join us and see your classmates and maybe you presenting various kinds of posters and other kinds of presentations. So thank you all for being here tonight.